Good afternoon and welcome to the Faculty Lounge on 89.5 WJMU The Quad. I'm Dr. Scott Lambert. I'm here with my wife, Jamie Whitmer, and today's very special guest, John Blakeman. How you doing, John?
I'm doing well. Great to be here.
I'm doing great, but I'm struggling today, and Jason still is laughing about that, but
there's a story here.
there is,
Uh-oh.
and it's bad. And my wife now has photographic evidence, which I think is even worse. So I go into my class today, and I sit down, and I start explaining why I am in such a horribly rotten, terrible mood. And it all started from Monday when the Democrats completely trashed themselves with the Democratic caucus. And then it went to the president's State of the Union on Tuesday, and then he gave Rush Limbaugh the Medal of Freedom, which just completely blew my mind. And then today, before I had to go into work, well, Wednesday they acquitted him, and then today I had to listen to him talk about that. And I start doing this, and the students are just laughing. And they're giggling, and they're laughing, and they think it's the funniest thing ever. And then Jason turns around and says, "You need to turn around." And one of my students had drawn a picture of me. Show it to the camera.
They knew it was
One
coming.
of my students drew a picture of me and said,
No.
"I'm angry because the Democrats screwed up in the caucus." Isn't that horrible?
I mean, maybe predictable.
Maybe. I guess I've got to become upset about something else. But yeah, that's the way my whole day started. Yeah.
How dare they?
I know. I mean, I get no respect. I guess that's just the way it is. I'm the Rodney Dangerfield of Milliken. So, you, how are you doing?
I'm doing well.
You haven't got students drawing pictures of you on the blackboard behind you?
Not yet. Give it time. It's just a few weeks into the semester, so they still have time to catch up with those things.
Catch up and do those things?
Yeah, it's going well. It's like I was saying before we came on the air, it's always, you got to get a little momentum at the beginning of the semester and starting clinical, and it's new for the students, new clinical side, and getting used to the charting system and where everything is and who the staff are. So I answer 50,000 questions the first few weeks, but it's to be expected. And as we get going over the course of the semester, then it becomes a little more autopilot, things like that. So it's just a little more draining on my end.
Well, the first part of the semester always is, and then the worst part is it's the most fun.
Yeah.
It really is, because you're working and you're doing an awful lot of stuff, and you're spending a lot of time, and you see the students learning more in the first part of the semester than you do at the end. Because by the end, you're tired of it, they're tired of it, it's warm out.
Definitely in the spring. That's around spring break. I mean, it seems like after spring break, it's just harder to get stuff done.
Yes, it is, because they're ready. And if you've got seniors, they're checked out, man. They are gone. So
I have a nice cross section. I have the first semester juniors, first semester seniors, and second semester seniors. So I get a little bit of everything. But it's also nice because, yes, you see them progress within a semester, but I also kind of get to see them over the course of their time in nursing school progress. So it's a great thing.
Yeah, I agree. I mean, Jason's over here. I've had him in 12 classes.
He's coming around.
I've seen him grow from, basically a snot-nosed little punk to the wonderful man that he is today. And he's grown a lot.
So with nursing students, do you see that with spring break? After spring break, do you see that? Because as a student, I remember when I was in gen ed classes, I took everything concurrently, so there was a stark contrast for me, where after spring break it did seem like in my English class or whatever courses. You were on autopilot, but then nursing school is so pedal down the whole way. So I didn't know if you quite see that as much as an instructor.
I see the desire on probably the part of the students to want it to be that, but it is, continuing on, because within each semester the information that's being learned continues to build, and it's not like what we talk about, well, even in the junior year, it comes back in the senior year, and so everything is continually building. And in the clinical setting, when we're taking care of patients, really it's getting more complex, and my expectations are going up every single week as the semester progresses. So yes, sure. The desire on their part is probably there after they get back. It takes them a little bit to get back on the horse, so to speak, for the second half of the semester, but it's pedal to the metal and pretty much through the end of the semester.
So at Millikan, do they have, like when I was a nursing student before spring break, I swear it was like they did this intentionally so that we wouldn't totally fall off.
Mm-hmm.
We would have like 1,000 pages to read, and by the way, there's going to be a huge test your first week back on this. Do you guys do that?
Not intentionally. There are times where we end up having an exam fall occasionally on like the Monday back from spring break. Sometimes it's on Wednesday, and it's not, in my experiences in my courses, it hasn't been because I want to make it that way. It's sort of where the units naturally fall.
Right.
And kind of when you think about how many days does it take to get all this information in for this unit, and where are the exams going to fall, we try to have exams on Mondays so mm-hmm. that we're not trying to finish material on a Monday and then they have to take the exam Wednesday, because a lot of them have clinical on Tuesday. So it kind of, if they learn all this stuff Monday, they don't necessarily have a lot of time on Tuesday to really sit with it and think about it. So we avoid at all cost Wednesday exams typically, and so it ends up kind of putting us in a situation where Monday is one of the only options, really, because they have their classes Mondays and Wednesdays kind of in seat here on campus, and then Tuesday and or Thursday are clinical days.
Mm-hmm.
So it limits things a little bit. So we do sometimes end up having the Monday after, but not intentionally. It's just kind of where it falls. But the attitude is, and I certainly get the idea that we all need a break, and we do need spring break and things like that. But at the same time, the information that they're learning, it's not like you can just forget it. So right. The argument that, well, we learned this before spring break, so now after spring break I can't recall it. Well,
right.
You're an RN on the floor and you're taking care of patients. I sure hope that you can recall this information
right.
because you're going to need it. So, sometimes the argument or the logic doesn't quite match up,
right.
on their end.
Sure.
But I understand the need, the desire for having the break, and I certainly need a break too, and I don't want them to be doing nothing but studying over spring break or fall break or whatever.
Right.
Now, you did have a good break this semester. I saw you at Christmas. Yeah. You went down to Florida.
Yep.
Took some really nice pictures. Had a good time. Where'd you stay at Disney World?
We stayed at a condo actually off of a property, which some of the times that I've gone, I've stayed on property. Sometimes I've stayed off property, and there are pros and cons of each, but. It was a good trip. We were there for about a full week, and so we were able to take a little more time at different parks, go back to places, which it's nice to be able to do. And I think what's amazing to me about Disney World is that it changes in some respects, changes overnight, and in other respects, some things look and sound and smell the exact same way that they did 30 years ago. It's just interesting how that works. But the last time I went was about 5 years ago. So it was a decent chunk of time between then and now. But yeah, it was fun time.
How was the Star Wars experience?
So I got to go on one of the rides. So I went on Smuggler's Run, which opened. I think it was over the summer and the fall sometime, but then the newest one, the Rise of the Resistance ride, opened in December, and so they're actually still working on ironing things out, and the downtime for it right now is pretty high. So I didn't get to do that one because they're using a boarding pass process now, where you have to pretty much be at the park super early in the morning, and within 15-20 minutes all the boarding passes are gone, and the boarding passes are for the rest of the day and tell you to come back at a certain time. So the actual design and the Star Wars, Galaxy's Edge part of Hollywood Studios is amazing, and so is the Toy Story section. Actually, I mean, as far as theming across all of the Disney parks, I think that those two areas are probably some of the best in terms of like your immersion into that world. Which, I mean, Disney already does a really good job of that anyway. So that's saying a lot, when you compare those two new areas.
Disney World, the actual, the Magic Kingdom, when I went as a teenager, I liked Epcot so much better. But I think now as an adult, I'm kind of an Epcot type of person anyway, so I would still love Epcot. But I think after raising my kids, and like the Toy Story was just such a big part of our lives for so many years, I think I would get a huge kick out of that. And then Star Wars, I would love to see that. So I have a reason to go now versus before. If we had gone, I think I would have gone to the Magic Kingdom, but Epcot probably is where I would have spent more time.
I definitely enjoy Epcot a lot, and it's you're able to do a little more adult type things, and just going around to the different countries, and I enjoy that a lot. I think what surprised me probably the most from 5 years ago to now is really how Animal Kingdom, how they've grown a lot of things there and are really sort of expanding, developing, and I think that it's going to continue to draw more people over time, which in the past it hasn't really been my favorite park, but there are more and more rides and attractions, and even at Epcot, they're in the middle of a pretty big construction project, and there were, depending on the day you'd go in, there would be a fake wall set up there, and the next day that one would be down and be something else.
Wow.
So they're doing a lot of renovation work and kind of rethinking things, but it was good.
Which park is your favorite?
It's a hard decision. I mean, I think ultimately, if I could only go to one, it would probably be the Magic Kingdom, just because in terms of the number of things that you can do, if you're thinking kind of economically and the bang for your buck, so to speak. But at the same time, it would be hard for me to go to Disney World and only do one of the parks, because I do enjoy it. Probably Magic Kingdom and Epcot are up there. And as the crowds and things get less with the Star Wars, I think that the Hollywood Studios will be a draw. But
Right.
How was the Smuggler's Run?
it was good. It was, if people have been on the Star Tours simulation ride, which has been at Hollywood Studios forever, I mean, that I can remember, even since back when it was MGM Studios before it became Hollywood Studios. But it's similar in the sense that it's a simulation, it's a simulator, and certainly the car that you're in moves and vibrates and bounces around, but it's a more interactive experience, and I think there were pros and cons to that. So whereas in Star Tours you're kind of sitting in the simulator in rows and just watching what's happening on the screen, you're not pushing buttons or doing anything. When you're in this new Smuggler's Run ride, I mean, you're, depending on which position you get assigned, whether you're the pilot, engineer, you have to do some pushing of buttons, and so it kind of, for me at least, some of the time I was just trying to figure out which button I'm supposed to push while the ride is still happening. So I kind of would have preferred a little bit to just kind of be watching and experiencing it and not having to do something. But I think, like, if you were in the pilot role, it would be probably more fun because you're actually up there and can pilot this simulator, and it does kind of take, it's not just a figment of their imagination. They're really able to make it go up, down, side to side, so they're controlling it. Now there are of course limits, they can't just like fly off into the universe, but they really can control to some degree what's happening with that particular car. So yeah, it was very well done. I mean, it's much better than any simulator probably that in most places, but I did think that it would be kind of nice to just sit back and watch.
My NP partner, Erin, went there recently, and the whole family and her daughter got to kind of be the pilot. I think her husband was piloting with her, but She said it was so intense. She gets migraines,
Yeah.
and it actually triggered a pretty horrible migraine type thing because it was so realistic, and you were kind of pitching and that type of thing. So, but she loved it. She was like, it was totally worth the migraine,
yes,
but
it was,
it was intense.
It is.
Then you got home.
Yes.
And you had to start school again. Isn't that horrible?
Yes.
I mean, hey, let's have fun. Oh, gotta go to work now.
I had a couple weeks in between getting back and starting back up. And, to some degree, though, I do better on a schedule and with some structure in my weeks. So, as far as going to bed at certain times, getting up at certain times during the course of the day, just having that structure and interacting with people. I mean, I think that's also, I forget how much interaction when I'm on campus that I have with colleagues, with staff, with students. And when you're on breaks, and don't get me wrong, there's certainly sometimes a benefit, at least for a while, of that, just to kind of reset and recharge. But then you start to miss that interaction and just the communication that you have with other people.
Oh, I agree. The summer's the hardest. Winter break.
Yep.
Winter
That's
break,
about right.
just about the time that I'm starting to miss the students, we go back. In the summer, I love the first couple of weeks. I'm like, oh
Yes.
my gosh.
Yep.
And then you're like, okay, let's do our research, and we're gonna do. And then you're like, is this summer ever gonna end? It's just hot out. There's nothing to do. Come on, I need students.
Yep.
And it's yeah.
Definitely.
So
Now, you recently had a journal article published, correct?
Yep.
Tell us about that. That's pretty cool. Congratulations, by the way.
Thank you. Yeah, it's really a continuation. Yes, thank you for the applause. Thank you. I appreciate that. So it's really a piece of sort of my overall research trajectory, my area of interest. So just for those that aren't familiar, my overall area of interest is cardiovascular disease. More specifically, I'm focused on acute coronary syndrome, which basically is heart attacks, and then to some degree also heart failure, and now I'm getting in also to a little bit of atrial fibrillation, kind of those core topics within cardiovascular disease. But then the other kind of major component that complements those areas is the idea of symptom science. So understanding how people experience symptoms, perceive them, attribute them, and then whether they are or are not seeking care for their symptoms, how providers assess symptoms and how providers listen to people and kind of interpret the symptoms that they're telling them about. And then the other large piece of my research, overall research program really is the idea of sex and gender and the way that those two variables really affect all of the aforementioned things. So how symptoms are perceived and attributed, but then also how as healthcare providers we hear patients telling us about symptoms. So really it's the cardiovascular topics with this idea of symptoms and understanding symptoms, and then sex and gender matched up there. So this paper really was published in Advances in Nursing Science, which is more of a theory researcher-focused journal. So it's not a clinical, your everyday staff nurses or nurse practitioners or what have you. They're not necessarily picking this up, but it's really more of a journal focused on nurse researchers and theorists and understanding essentially the idea that sex and gender are two different variables. And so a lot of times when we look at research articles or when you look at even surveys, questionnaires, and things, people will have to often indicate their gender, when sometimes really what they're asking about is sex or vice versa. And so this article essentially was defining what do we mean by sex, what do we mean by gender, what do these two constructs, these two variables mean, and then using the cardiovascular disease literature as this exemplar to kind of say this is why it matters, kind of outlined, so here's how gender makes a difference, here's how sex makes a difference, here's how both of these make a difference. And so that was the kind of middle part of the paper. And in the third part of the paper, it was, okay, what now? So as researchers, as nurse researchers, theorists, as we start to do more research and as we develop more theory or refine theory, we have to be very cautious and precise about how we measure things. So if I want to know about biologic sex, then we need to be very explicit about how we measure that, how we think about that. If we're really interested in gender, which sometimes in more social research, gender may play just as much, if not more of a role than biologic sex does. And so the last part of the paper was sort of from a researcher theorist perspective, how do you operationalize this in a research study? What do we do about the research that's already been published? How do you look and determine, should I measure sex? Should I measure gender? Should I measure both within a study? So that was kind of, it's more of a, not a research article, but a theory research methods sort of an article.
Okay, I've got a couple questions.
Yes.
First, we're here on 89.5 WJMU The Quad. Tell me, when you're actually doing nurse research, when you're actually doing research along those lines, what is the difference between sex and gender?
Sure, it comes in a lot of different flavors, and so there's not one absolute, this is apples, this is oranges, and admittedly it can be difficult to know sometimes what you need to measure or what you're trying to measure. But in a nutshell, when we think about sex, we're really talking about biologic sex, chromosomal composition. So when we look at the 23rd chromosome, what are we actually seeing, sort of a thing. Now, we know that about 1 in 50 people has a chromosomal composition that really actually isn't a strictly male or strictly female composition. So really the term is intersex that is applied for those people. But there are certainly things about biologic sex that matter. So from my symptom research area, for example, we think about the size of the coronary artery. We think about the mass of the heart. We think about hormones, things that, based on a person's biologic sex, are going to vary simply because of whether somebody has an XX or an XY for their chromosomal composition in terms of male or female. From a gender perspective, the point I always make here, because I know there's a lot of debate about, well, sex and gender, and people get really bent out of shape when we start to say, well, someone's sex and gender may not match. And the way I approach it is, well, you're entitled to your opinion about that, but when you look at the definitions of these two things, they're different. And as researchers, we need to operationalize and use variables the way that they're actually defined. So gender is more of a social construct. So certainly when you look from culture to culture, things that are more of a masculine or more of a feminine sort of role, it's going to vary. And so when we think about gender in terms of cardiovascular disease, sometimes that plays itself out in how people cope. So, and there's also certainly an interplay with gender and other factors. So when you think about gender in rural areas, for example, coping for those who are more masculine, and this is, the unfortunate thing about gender is there often are a lot of generalizations made, which we know that everybody's different. And so, when we start to talk about generalities, it's a little, slippery slope sort of a thing. But we think about, those who identify as more masculine often don't want to express their feelings as much or make them as verbal. And so as coping mechanisms, they may turn more to alcohol. We also see, use of other substances like cigarettes and things like that, that may be more based on gender roles or how they interpret a man should act or how a woman should act. Also understanding just how people in their own everyday lives perceive responsibility. So when we look at women, and something that came out in my research study and a lot of the symptom perception, attribution, care-seeking literature, is that a lot of women feel that they are ultimately responsible for their family. And so, even though they're experiencing symptoms, even though they think maybe their heart, something's going on, they may delay and sort of have this idea of, I'm responsible for these people. I can't seek care. I can't do these things because I have to be like the responsible one and take care of my family and do the things that the mom or the wife or whatever should. And so, and that's an overgeneralization in terms of what happens on an individual basis. But sex and gender, certainly they're not the same. And so what I see a lot of is when people will say gender when they really mean sex. And I think it's because people just don't like to use the term sex. And, and when we're asking people about, sometimes we should ask about both, really. Some of the research in the cardiovascular area that's been done has looked at understanding cardiovascular risk and people's risks of heart attacks long term, and they've measured both sex and gender. And so there was one the Genesis Praxis study where they actually compared the sort of the predictive ability of sex and the predictive ability of gender, thinking on that sort of masculine to feminine scale, which ones and how they predicted future cardiac events. And they found that sex didn't have a huge effect, a huge predictive effect on the outcome of these cardiovascular events, but gender had a significant, much larger effect on those long-term cardiovascular events. Essentially telling us that yes, sex probably has some role to play in terms of composition of your your overall body organs and your hormones and all that, but there's also probably this real effect that comes down to stress and sleep and how we process our emotions and the things that we do to cope with these things. So there's a role of both to play.
So science is behind on, I'm not going to say behind, but maybe a little bit behind in its studies of women and heart disease. And you're catching up and you're starting to do women-specific or female-specific studies. Have there been a lot of studies that have looked at transgendered people or people who identify different when they come to...
Not a ton, and it's important because certainly we know, especially when you think about the therapies that are used to assist people for gender affirming therapies, that if we're using testosterone, for example, to help people affirm their gender, that's going to increase cardiovascular risk just in that one medication that's being used, throwing aside all of the stress, the overall external pressures that those individuals feel overall. So there hasn't been a lot of specific work with that. And gender itself, I mean, when you look at most cardiovascular research, they're really focused on biologic sex, even though they often don't really make that clear. Sometimes it'll say gender, and you read the article and you think, really, they weren't measuring gender. They were really measuring sex.
Have there ever been studies that have specifically concentrated on the LGBTQ community and their risks?
Yeah, there are some, and it gets a little bit tricky in how we parse out what's contributing to the risk, how much is it contributing, because when we talk about the LGBT community, really there are multiple aspects of that add risk. So it's the overall lifestyle that may have part of the, explain part of it. It's overall, again, stress, the judgment people may feel, the social sort of issues that surround that. But then again, with like transgender, you're talking about actual therapies that we're doing that increase risk, and there's more smoking, there's more substance use, probably to cope with a lot of these other social
and depression and issues you're dealing with.
And so it's like in research, in an ideal world, we could tease out all these things, and there are methods to do that, but it's hard. You have to have very large samples. You have to be able to adequately and precisely measure all these different things, so it becomes very complicated.
And it takes years.
It does. Yeah. It does.
That's what I was going to say. It takes time. So where we had the Framingham study, which is a huge study that that took place over a long, long period of time, and for a very long time, only men were involved. Yep. And we realized, we need to study women too. Now we're realizing, what? We also need to be studying the LGBTQ community and the transgender folks, and this becomes really complicated really quick.
It does.
And even though we have some research on the LGBTQ community, we don't have that long-term research that is really necessary and crucial in cardiovascular risk assessment.
Right. Yep.
Because it's such a long-term thing that generally doesn't just boom.
Well, and in cardiovascular research in general, we have, I think, acknowledged, this idea that women have been underrepresented. We're getting now, I think, to the point where at times, the way that we, from a research perspective, differentiate things can sometimes get a little fuzzy when that gets taken into sort of the clinical or the media side of things. So I see that a lot with heart attack symptoms. And I think, it's February, it's Heart Month, right? So, for those that are watching, listening, oftentimes when I talk to women who I tell them my research topic and what I study, they say, oh yeah, I know women have different symptoms than men. I said, but do you know that still the most common symptom that women experience as an acute symptom is chest discomfort of some sort? For both men and for women, chest discomfort is the number one symptom. And so sometimes I'll hear, oh, I didn't realize that. I thought women had like jaw pain and neck pain. And, maybe that they just had a little back pain. And so I think, some of the headlines that, oh, women have different symptoms, sometimes it's statistically significant. So maybe, yes, women had, 60% of women had chest discomfort compared to 68% of men. So is that statistically significant? Well, if the study was big enough and so forth, yeah, maybe it was statistically significant. But from a clinical perspective, and when we broadcast that out to people, I think what sometimes people hear is, oh, women don't have chest pain, men do.
And the majority did.
But still the majority do. And that, it's true. And women have more symptoms on average, and more we used to call it atypical, because the typical symptoms were the ones that men had, right? But so they would have more fatigue and more shortness of breath, indigestion, sort of anxiety, not, just this overall malaise. But they still had chest discomfort. They still had shortness of breath. And there are some men, remember, maybe only, there's a good chunk, 25% or more of men who don't really have clear, crushing chest discomfort, that how we might, often think of it. So what I usually say from a symptom perspective is we need to get a little bit away from saying these people have these symptoms, these people don't, and saying here are all of the key signs and symptoms that a person can experience when they're having a myocardial infarction, a heart attack, or in the weeks and months leading up to that. Because it's hard when you take science and statistical significance and all this and then try to package it into this short bit on the news or what have you, because people are going to hear just that little bit and not delve into what the results really say.
I'm also becoming increasingly more convinced, and I may in the future become increasingly less convinced, because things evolve, but that men and women have the same symptoms, but how they perceive their symptoms are so much different. Yep. So as a clinician, men are so much less likely to come in with a chief complaint of fatigue than a woman.
But
if you're screening about it, but if you're screening for it and you're asking them, men will fuss up. But men, in my practice, which is, admittedly a very small group of people, and I could have biases built in that are unfair, or, but men tend to power through and not complain about some of these. Yes,
gender issues.
Exactly. Yeah. But when you ask about it, it's there.
Yes.
Yep. So.
And to add complexity to the whole, men versus women thing, when you look across cultures, when you look at studies conducted in Asia, you look at studies conducted in Europe, and then you look at North America, so you look at all these different continents and sort of the way that people perceive symptoms. I was just looking at a study the other day that I think only about 25% of the patients that they sampled in Asia had fatigue, compared to in the U.S. where you're looking at about 3 and 4 have fatigue in the weeks and months leading up to an MI. And to me, I think, is that really a difference, or is it the way that fatigue is perceived as an overall thing,
right,
among and across cultures?
And it depends so much on how you're asking the question, and sometimes you have to ask things a few different ways. And in the era of the 10 to 15 minute appointment slot, do we have time to ask these questions?
And if they answer yes, then yeah, oh yes, I'm fatigued. Well, now we have all these other questions and other rabbit holes to have to kind of investigate.
Right.
Yep.
Wow. You see, this is it. We're Dr. Radio whenever you're on. And, you know, I'm just sitting here like, yeah. Sports. Good. So, you're close.
I'm good, yep.
You
February
are almost
24th.
a PhD, a doctor nurse.
Yeah.
So February 24th.
February 24th at 10 a.m.
Are you
That's when you
nervous?
defend?
That's when I defend, yeah. I'm not really nervous, and I suppose I probably should be, but I've kind of gotten to the point where I have talked about this so much, and I have read so much that I know and this is going to sound bad, I don't mean this to sound bad, but I know more about this than anybody else in the room at this point, because I've lived it and breathed it for the last, really since my master's program, so for 6 years now at least, I lived it and breathed it, and so it's really, I feel like I have become, I won't say an expert, but close to an expert in that particular
you are
area.
an expert.
I was going to
That's
say, you're
why-
finishing your
Yeah.
PhD. You
That's
are
why
an
you
expert.
Get your PhD. And you know, that's the one thing that I've always noticed, and I always use this as an example, you know. I am an expert at one thing. I am extremely well-versed and knowledgeable at one thing.
Mm-hmm.
And I used to play basketball with the faculty group at SIU.
Mm-hmm.
And I played among some of the smartest people in the world, people who were all extreme experts at one thing, and none of them could count to 10.
Yeah.
All right?
Yeah.
And that is a very large thing, and that's part of what we
Interesting,
do. When you do and go through the work to become a PhD, you are putting all of your intellectual capabilities into one thing, so that you are an expert on that one thing.
Yep.
And you know, it's a lot of work. It's something that everyone should be proud of. The day that you get it, I promise you, I will be screaming in celebration.
Well, thank you. I will be too.
I know you will be.
Yeah.
I know you will be. And then the next thing that you have to think is, I'm an expert at this.
Yep.
But I have no clue about so many things.
Yep.
And that's, you know, and it's extremely important for all of us to remember that.
Oh yeah, and to I think, because I want to continue to do more research, continue
Right.
to expand, continue to get grant funding, which what that takes is building a team and having a group of researchers, that so maybe symptom science, cardiovascular disease is really my focus, but there are other people with other specialties that I should bring in or I should join to really do the best science. Doing a study on my own, generating my own research questions and my own literature reviews. On the one hand, yeah, it's nice because you can control it all, and it's going at my pace and, I'm doing what I want. But when it comes down to it, having multiple people contributing their ideas and their expertise to the development of research questions and to the development of how we're going to do this study and then the analysis, it's good to have multiple eyes and to have people that have differing perspectives. I really think having qualitative, quantitative, mixtures in terms of methodology, specialties, it's just because everybody comes to the table and says, well, we could do this, and that would capture this thing and that thing that you were trying to get to, but then it also allows us to look at this, and so there's a lot more, synergy when you get multiple people in the room, and I think it really does. And for grant funding, it's almost a necessity. I mean, it really, to get significant grant funding, you have to have multiple people with specific expertise in a lot of areas in order to secure large grants.
Okay. So we have to mark that on our calendar.
February 24th.
February,
10 a.m.
what day is that?
It's a Monday.
It's a Monday?
Day before my birthday.
Really?
So my goal was so that I could say I defended my dissertation the day before my birthday.
That's very good. And hopefully you don't have to do any rewrites or anything.
Fingers
and it's
crossed.
good.
Fingers crossed.
They take it and say, yeah, you.
We can only hope, but
Yeah.
there will be questions. There are always
There
questions.
are always questions. I understand, but hopefully things work out. I'm excited for you.
Thank you.
So from there,
Mhm.
what else have you been looking at?
Well, a ton of different possibilities. I mean, in terms of research trajectory moving forward, I think I'm drawn to this whole idea of symptom perception and attribution, and then how people either seek care, go to the doctor, go to the ER, or not. I mean, it fascinates me how that varies. So, in my research, the dissertation was mainly focused on the overall symptom experience. What does the symptom of fatigue look like? Because when you ask somebody, what does fatigue mean to you, that varies quite a bit. Is it tiredness? Is it weakness? Is it lack of energy? Is it all of those things wrapped into one? And so that's really what my dissertation is focused on. And what I've increasingly realized from my dissertation and having the multiple conversations I did with women who had a heart attack, had fatigue before that, was that it's not all about knowledge. So oftentimes people think, well, if people just know the symptoms of a heart attack, they're going to seek care whenever they have them, right? If they're having chest discomfort off and on, especially when they get up and they start walking, or if they're having more and more shortness of breath, or if they're having more fatigue, well, they'll go seek care, because if you know that those are the symptoms of a heart attack, you'll do that, right? Well, I say, I like donuts. I know they're not the best food for me, right? I have that knowledge. Like, I shouldn't eat, a box of donuts, but sometimes they just look really good and you eat your donuts. So knowledge is one piece of understanding symptoms, but what study after study, and including my findings, have shown is just because people are experiencing symptoms that they know are symptoms of a heart attack, they often still don't seek care. And there are some interesting, unique variables, I think, that things like understanding of vulnerability and your own risk. So not to say that people think that they're invincible, but patients may say, well, yeah, I know these are heart attack symptoms, but I didn't really think that I was a person that could really have this yet. Maybe because I'm too young, or maybe because I don't smoke, or whatever the case might be. And so there's this idea of, do people have vulnerability, or have their own sense of vulnerability, and their overall understanding of risk. So, they've looked at patients with diabetes. Diabetes is a significant risk factor for the development of cardiovascular disease, right? And in that population, there are still a number of people that don't really feel like they're at increased risk of cardiovascular disease. So if they don't really understand their risk, or their idea of being vulnerable, that's one thing. There's also, the idea of how people cope. There are several different theories about coping and symptom interpretation, but the general idea is that when people are experiencing a symptom, sometimes they'll kind of downplay it, try to explain it away as much as possible, because it reduces the anxiety of there possibly being something wrong. So and we see that not only in cardiovascular disease, heart attacks, but patients that maybe have signs and symptoms of cancer, or signs and symptoms of other really severe, significant things, but they don't want to find out. They don't want to go to the healthcare provider.
Because when you go to the doctor, when you go to the healthcare provider, they're going to tell you that it's there, and it's
exactly.
That's bad news.
And you have to sort of face that. And what's fascinating though is, at the same time, you can say, well, do you know though that not seeking care is perhaps going to make the situation worse, right? I mean,
absolutely.
And sometimes logic doesn't quite, and it's what's fascinating to me, is in thinking about human beings and human behavior, how it's like, this is true, and yet I'm not going to go seek care.
And there's even when there's something really acute, life-threatening going on, people will react differently. Some people with crushing chest pain and can't breathe will go straight to the ER, and other people won't go until they're unconscious and somebody calls. There are a significant number of people, this happens more in women, but a significant number of people who are actively choking will run out of a room. So instead of doing the universal choking sign where they're, grabbing at their neck and things like that, these folks get out and they run into, say, a bathroom. And so, by the way, if you find somebody unconscious at a restaurant in a bathroom, think choking. But, aside from that, it's like, what makes us do that? What makes some people do that versus other people, are grabbing at their neck and doing the universal choking sign? And who knows,
There are so many factors. I mean, it's the idea of vulnerability, risk, age. In my study, there were a lot of people that attributed their fatigue to age and comorbidity. So they said, well, I've got COPD, emphysema, diabetes, and I just figured it was that, kind of acting up, or, well, I'm in my 80s now, and I just kind of thought that was probably normal and what I should expect. And so there are multiple, it doesn't come down to one thing. Like pretty much everything else in research and in healthcare, it's not about one variable. It's about a million. And that's what is exciting and interesting to me, is kind of teasing out those things and what's most important, because at the end of the day, that's what it comes down to. We don't have 5 hours to sit down with patients in the clinic setting. And so we have to think about what are the most important, most critical aspects of this. And that's, I think, in research, one area that's important, and one that I like to think about is, how can my research be clinically applicable? How can someone actually use this to change their practice or to better inform their practice? And sometimes it's not as doable. You have to kind of do this study and this study before you can get to that next study. But at the end of the day, I'm always trying to think, okay, as a nurse or as a physician or nurse practitioner, how can this be used moving forward? Or what's my long-range plan so that this can be clinically applicable?
Absolutely, absolutely. All right, in a minute we're going to do something here that's going to be real fun and interesting. We're going to play a little game of musical chairs, so Jamie can sit here and start talking about you guys and Wuhan virus and coronavirus and Bud Light virus and whatever else they've come up with, and we'll go from there. But right now, I just want to make sure everyone knows we're on 89.5 WJNU The Quad. Jason is very happy with me because I've mentioned it twice now, and we'll be back. Or we're not leaving. We're just doing a little bit of job of musical chairs.
Let's take a break. We'll do a quick break. Jason, the boss here, is saying it is break time.
Okay, we're going to do a quick break.